Good afternoon. My name is Natalie and I am one of the PACOP team. And today in PACOP in Practice, we are going to be looking at the DRT, the Deteriorating Resident Tool, and specifically how to use it to ensure better care, better communication, both from the resident's point of view and also from the team. So I'm just got a PowerPoint up here, which I'm just going to go through. First of all, I would like to start with acknowledgement of country. So we wish to acknowledge the Aboriginal and Torres Strait Islander people as traditional custodians of the lands we are meeting on today. We wish to pay our respects to the elders past, present, emerging and future. So we'll start with just a little bit of a recap about PACOP, what it is. So PACOP stands for those of you that don't know, Palliative Aged Care Outcomes Program. It's funded by the Australian Government Department of Health, Disability and Ageing, and the aim of it is to improve palliative care delivery to ensure a better death for residents, for people living in residential aged care. It has been going now for about 4 to 5 years, and it has been developed out of a long-running program called PACOP, which is used by the general and specialist palliative care sector throughout Australia. Essentially what PACOP is a really robust, standardised framework of assessment that begins right from admission and continues throughout a resident's time living in residential aged care, right up until death, with the whole purpose of making sure that if we can have appropriate care at the right time according to their assessed need. Now, today we're talking about one particular part of the program, which is the Deteriorating Resident Tool, or the DRT. That's one of the forms or the assessment forms that make up our profile collection. As you know, as you may or may not know, PACOP is divided into two parts. We have Part A, essentially, which is the profile collection, and Part B, which is outcomes collection. Outcomes selection really is designed at assessing residents who have entered the last 3 months of life, and the profile collection is a screening assessment framework which starts right from the time they enter residential aged care so that we can pick up when it is that last 3 months of life to start them in outcomes and therefore to increase the amount of times we do assessment, but it's because, of course, we know in the last 3 months of life, things change really quickly and we need to be assessing them much more regularly. Now, just to set the tone, really, to set the picture, we're just going to run through a few stats, which you may or may not have seen before, but these are from the Australian Bureau of Statistics. So in 2024, there were 223,000 approximately beds in residential aged care in Australia, spread over 2,600 odd aged care homes. In the year 2022 to 2023, about 65,500 people died whilst living in residential aged care. Of that 65,500 people, we had 12,000, so 18%, so 1 in 5, really 20%. 20% of that 65,000 died within 3 months of being admitted. And 36%, so that's 25,000 odd, died within 12 months of being admitted to residential aged care. Why that's really important is because it really sets the scene for everyone to know that when someone is admitted to an residential aged care facility, they are already clinically deteriorating. If they weren't deteriorating, they'd still be living at home with home care help if needed, or with family or friends. By the time they are admitted to residential aged care, they are already on that downward trajectory and are already clinically deteriorating. So we need to know how to monitor that deterioration, how to swing to action when it looks like it's last 3 months of life, how to just make sure that we're assessing using the right tools so that we can pick up the things that indicate deterioration, all with the sole purpose of being able to then address those needs in the care plan and the care that we provide to people. So just a recap of the process and where the Deteriorating Resident Tool sits in terms of PACOP. We have the two collections, as you will know. We have the profile collection, which is the purple one on the right. That's made up essentially of two forms. The profile 3-part clinical assessment form, which is completed on admission when people come into residential aged care as part of the admission paperwork. Ideally, it gets repeated every 3 months and also on return from hospital. And then sitting alongside that, the other tool in the profile collection is the Deteriorating Resident Tool. And that's the tool we're focusing on today, but you can't have one without the other. And then, of course, we have in the orange section is our outcomes collection. That is for when we have identified someone as being probably in the last 3 months of life, through either doing the Profile 3-part clinical assessment tool or the deteriorating resident tool. Through one of those avenues, we have identified that they are likely in the last 3 months of life. We then stop them on the profile and start them on outcomes. And essentially the outcomes is just an increase in the frequency of assessment, because we've already identified that they are deteriorating to a point whereby we're thinking that they have less than 3 months or less to live. And we'll also do, in outcomes, we do away with all the extra questions that we collect on the profile forms and really just focus on their symptoms and problems, performance and function, so that we can make sure we are on top of all their needs at any time. So today we're looking at this one, the deteriorating resident tool. All right, so we're just going to quickly go through the process and the tools we use because it is all relevant to picking up deterioration. The profile, this is the 3-part clinical assessment form, which is used on admission. And why it's important it's used on admission is because we know they're already deteriorating, but we need to capture how they are on admission so that it gives us a really good baseline of the resident. So that it's got something we can refer back to when we're trying to establish how much deterioration has occurred. And also, it gives us really great information to make sure we're developing their care plan to meet their current needs. So this is what the profile form looks like. It has the Part A, which is where the clinical assessments sit. Part B, which is a few questions about their reason for care, also about their advanced care planning, and also about recent hospital use. And then Part C is the 3rd page, and that is the action plan, which is divided into 2 parts. The first one, identifying the need for palliative care. That's a sort of a checklist that you work through to help you think about what you've just assessed and to work out, well, based on what I've just assessed, does it actually look like this resident should be starting outcomes now? As in, does it look like this resident is likely to be in the last 3 months of life, bearing in mind that none of us know for sure. So it is a guide. It is a guide. And then the last part is literally the action plan, what you need to go away and do. Now, the other tool in the profile collection, and the one we're talking about today specifically, is this deteriorating resident tool. Now, the deteriorating resident tool is really just made up of the assessments. It doesn't have any of the extra questions that the profile has in it. It also has a simplified thing at the bottom of the 2nd page, identifying the need for palliative care, which again is designed for you to do the assessment, work through the checklist to help you clarify in your own mind what the assessments are telling you and what you need to go away and do next. It's really no more complicated than that. And then, of course, we go to our outcomes collection. Once you've identified someone's in the last 3 months of life, you start them on this. This is what our form looks like. It may look different if it's in your software program, but essentially this is just the assessment tools, and they are done either weekly or daily, depending on their phase. So we'll talk about this a little bit later, the outcomes collection, but essentially once you've started, for the purpose of today's talk, once you've started someone on outcomes, you've already picked up that they have deteriorated to the point whereby you think they are possibly in the last 3 months of life. So that is why you've started them on outcomes, so you're already more frequently assessing them. So the deteriorating resident tool, which we're talking about today, will be required no longer, because this is you've already put into place to start them on this assessment framework, which is a quite different to the profile in that at a minimum they're getting seen once a week, and when things are a bit awry, like if their phase is unstable or terminal, then a nurse is assessing them every day. And then alongside, of course, that outcomes form is this daily SAS form, which we ask and we train the care staff to have those great conversations with the residents that we've identified to be in outcomes, with the sole purpose of getting information so that we can make sure that we are addressing what is of concern to them, what's worrying them, what's going on in their head. If we don't know about it, we can't fix it. This is another valuable tool. But again, this isn't the topic of today, so we'll keep moving on. So the deteriorating resident tool brings us to the deteriorating resident. How do we know a resident is deteriorating, and who can notice that a resident is deteriorating? Well, first of all, we already know everybody is clinically deteriorating already by virtue of the fact that they're living in a residential aged care facility. So how do we know if they're deteriorating to a point when we need to pick up on it? Well, we actually can't know. We cannot know unless we assess. We can think, But unless we assess, unless we're using assessment tools that are assessing the information that needs to be assessed, and then of course we can refer back to how they were previously, like their baseline assessment of their profile assessment when they came in, we can't know. As particularly in residential aged care, we're seeing our residents every single day. And if someone is deteriorating at a very slow rate, it's very, very hard to pick up. You know, if you, for instance, if you go on leave for 4 weeks and you come back, you can notice quite a marked difference in some of the residents. But if you're seeing them every day and the change is incremental, very, very hard to pick up. So how do we know? Well, unless it's really obvious, like they've become suddenly or acutely unwell and they go to hospital, or they have a fall or something like that, we can't know. We cannot know without doing assessments. That is the importance of using assessment tools, and that's the importance of using assessment tools in a framework, because if they're not used in a robust framework at specific times, then they might not even be picked up to use, and they're going to be absolutely useless to us. That's why it's the PACOP brings it all together in the framework. The framework is as important as the assessments because it makes sure it gets done. Who can notice? Anyone can notice. This is not, noticing deterioration is not the domain of the esteemed healthcare professionals. No, 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 this can be anybody. So, and often it's not the busy nurses that notice. It can be care staff. It can be as simple as a care staff coming up to you as a nurse and saying, you know, Mary's, I don't know what's wrong with Mary. She just seems a bit funny today, and she was a bit funny yesterday. Or it could be a family member coming up to you. I'm not sure, is Dad okay? He doesn't seem like himself. It is not the domain of nurses purely and simply to notice deterioration. It can be anybody at all. And as nurses, I assume most of the people on the webinar today are nurses. As nurses, we have to always keep in our mind that any sort of change picked up by anyone is worth investigating by us, because we obviously are looking after the clinical care of the resident. And the best place to do that is to pick up a tool which has got validated assessment tools so that we can assess the right things. And that's where the deteriorating resident tool comes into place. So if you're a nurse, we all know that the clinical indicators of deterioration are as follows. We have weight loss, we have unplanned hospitalizations, we know we've had to ring an ambulance, they've had a fall, or they're just unwell, they've gone to ED. Either they've gone to ED or they've been subsequently admitted to from ED to hospital. They're unplanned hospitalizations, excellent for prognostication of deterioration and can sometimes take us unawares. Increasing symptoms and problems. Of course, that is an indicator of deterioration. Decreasing level of performance and function, which leads to increasing care needs. Now, increasing symptoms and problems can be so slight that we're not really, noticing it unless we're assessing it. It all comes back to good assessment using the right assessment tools. Decreasing level of performance and function. Again, someone's needing a little bit more help with their ADLs. We're not monitoring it. The care staff are looking after them. It can easily slip us by that someone is having increasing care needs because the care staff are just making those small incremental changes as they're helping them every day. So we know these are all indicators, clinical indicators of deterioration. And guess what tools assess them and pick up all these things? It's the tools used in PACOP. I can say that PACOP didn't invent these tools, but the beauty of PACOP, which is developed from PACOP, is that these tools assess what's needed to pick up holistically clinical deterioration and therefore, going down the track palliative need so that we can address it. We talked about in the previous slide, clinical indicators of deterioration. Symptoms, increased symptoms and problems is one. The PACOP SAS, the symptom assessment scale, which is the resident rated tool, obviously, resident rated tool of 7 most common symptoms that people may experience as they deteriorate. And we're rating the distress level of the resident. So how much is affecting them, worrying them, stressing them out, distressing them. And then we have the problem severity score, which is the clinician rated tool that also assesses symptoms and problems of the resident in 4 domains. So that's what we have for pain and other symptoms, which is one of our indicators of clinical deterioration. The next 2 tools we've got here, we've got the AKPS or the Karnofsky and the RUG ADL. Both of these tools measure performance and function. A decrease in performance and function is a clinical indicator. These are the tools that are going to pick up on that. And then also we have included in the suite of tools that PACOP uses the Rockwood Clinical Frailty Scale, which is entirely appropriate in this cohort of people because for most people, frailty does increase with age. Not with all people, but for most people. And increase in frailty is an excellent prognostication tool of decline and deterioration. And then, of course, the other tool that we use in our outcomes part of our program is the palliative care phase, the phase of care. And that really is a triaging tool to help us work out when we need to next assess, which is not really the topic of today's talk, but if we get time, we'll touch upon that. So this is what the deteriorating resident tool looks like. If it's in your software system, obviously it will look, however it looks on your software system, but it should be set out the same. You'll see that we're looking at here, we're only looking at 4 of the assessment tools. We've got the SAS, the smiley face tool, which is a symptom assessment score according to the resident. Hugely important tool because this is where we find out what is upsetting or of concern to the resident, which we can't possibly know unless we ask them, unless we have a conversation with them. And then we have the other side of the coin. We have the problem severity score, which is a clinician rated tool. So we put them together. We get 1 according to the resident, symptoms and problems of concern to them, 1 according to the clinician. I put them together, get the most holistic view we can possibly get of all the symptoms and problems that are of concern for that resident at the time of assessment. Then we have the Karnofsky, which is underneath, which measures performance. And of course, the Karnofsky measures what a person does, not what they're capable of doing. So Bob, for instance, might be capable of walking around the facility. Bob might be capable of participating in activities, but what Bob actually does is sit in his chair all day and only gets up to go to meals. So that's what we're assessing with the Karnofsky. And then we've got the Rockwood Frailty Scale, which assesses frailty on a very easy scale from 1, very fit, all the way down to 9. Now, with the obviously with the Karnofsky performance scale, most people are not going to be in your facility until they're probably a 70 or a 60. And as someone clinically deteriorates, you would expect this to go down. With the Rockwood Frailty Scale, you would expect this also to increase as they deteriorate, but not always. And then we've got, at the end of the deteriorating resident tool, that nice little simplified checklist identifying the need for palliative care. And once again, it's designed to help you think about what you've just assessed and make a decision what to do from there. So the deteriorating resident tool is PRN. It can be done as often as you like, as many times as you like for any resident, for any reason. So, we've talked about the example before of, okay, we've got a family member come to you and say, look, I'm not sure what's going on with Dad. He's not quite right. Where do you start? This is where you start. Just grab this tool. This really should be your go and grab tool. This should, as a nurse, really, this will be your best friend tool because, sometimes when we're not sure what's going on, you don't even know what we're going to be looking for. And then we can, with this tool, what it actually does, it gives us objective assessment information to then determine what we're going to do with it. So we've all had those terrible phone calls or interactions with doctors and GPs where we've asked them to review a patient, if you're in a hospital setting, or to review a resident if they're in an aged care setting, and they sort of say, why? And we sort of stutter and stumble. I'm like, well, they're just not themselves. This deteriorating resident tool actually turns that your concern about a resident from being subjective, as in you just know there's something off about the resident, you've got a gut feeling, to objective. These assessments are objective assessments. So what this does is give you information to convey. So, you've done this today. Let's say Bob's not great. The care staff said to you, can you have a look at Bob? You go and do this and you're like, oh, actually there is an increase he's got an increase in his pain SAS score. Also his problem severity scores up. I've looked at his med chart. He is actually utilising most of his PRN medication for pain, for instance. There's not a lot of wiggle room to go and he's got quite high pain scores. Perfect. This is information you have to ask the GP, could you please come and review Bob? He's like, why? Okay, we've assessed him today. You can provide this to the GP if you like. We've assessed him today. He's having a lot more higher symptoms of pain. He's using most of his PRNs. We need to review his medication. So, this is the sort of thing that it helps you with. And other things helps with, family concerned about a resident. You can do, okay, no worries, I'll go and have a look at mum. I'll see how she is. You can go and do this deteriorating resident tool on them, and then you can convey back to the family, look, I have assessed mum today. Nothing much has changed. We do keep on top of her, assessing her regularly with PACOP, and nothing has much changed today, but we will keep our eyes on her. And the beauty of this tool is if you're still concerned tomorrow, or someone else is still concerned tomorrow about Mary, you can do it again. So this can be done as often as you like. The other great thing about this tool is that it also, it's, as nurses, it's evidence. It's evidence that you've done something. So any concern from anyone, this is your evidence that you've gone and investigated it. This is your assessment. And then, there's no point, we all know there's no point doing an assessment of any kind unless there's a response. So even if your response is to look at the assessment that you've done today and say, actually, according to this, Mary looks okay. I'm not going to do anything at the moment. I'm just going to monitor. Perfect. That is actually your response. A response can be you've looked at the information and decided nothing needs to be done. That actually is a response. So this is a great thing to evidence good clinical care, respond to concern of anybody, and can be done as often as you like to get help. As a nurse, you've got so many residents you're stretched out looking after. This is a tool that's going to really sort of give you peace of mind that, okay, I was concerned about this resident today. I've done the DRT on all of them. I've organised a doctor's review for this one. This one was okay. And then you document, and of course you share with your colleagues. So, we've talked about the versatility of the tool and when is good to use it. Family concerns, this is a perfect tool to use with any family concerns. It reassures the family that you are doing something about it. You can go back to the family with the outcomes of the form and explain to them, what the different assessments mean. It may also then lead you into a conversation when it's the right time to start outcomes. For instance, you've done a deteriorating resident tool on a resident today, and it's really showing some marked deterioration in all of the assessment tools. So have a chat with your clinical nurse manager or with your clinical team. Look, I've done an assessment on this resident today. It's actually showing, I think it might be time to start this resident on outcomes. And then again, this is the form that you use to have a conversation with the family, like those hard family meetings where you have the family sort of a little bit resistive to talking about palliative care and end-of-life care. You can say, look, we've done this on mum today compared to when she came in. This is how she is now. And they start to join the dots themselves and they start to say, oh, yeah, you're right, actually. Yeah, mum used to be able to come out with us for the day. Now she's sort of tired and wants to come back after half an hour. And it's just really good. It's good information to the nurses that makes you feel confident to have conversations with either your GP, with your family, with your specialist palliative care providers. So as we've got listed here, family concerns is when you do it, care staff concerns, nurse to nurse concerns. And we'll talk about this in the next slide, but I mean, when you're handing over to the next shift, obviously you should be speaking about any sort of incidents or residents of concern. This is where the deteriorating resident tool comes into it. Any falls, any hospitalizations, a deteriorating resident tool should be done because, again, what it's doing is giving you assessment information that you can use to refer back to previous ones to look for change and to look for an increase in those care needs, an increase in those symptoms and problems, to help think about, okay, is it the right time to start them on outcomes? Because really starting them on outcomes, all it's doing is saying, we're concerned enough about you to think you're possibly going to die within the next 3 months. So we're going to assess you more regularly so we can be on top of everything, which is what we would all want as people approaching end of life. Change in usual behaviour of a resident. Sometimes, Bob may have been this way for the whole time he's been with you. All of a sudden he's starting to act differently and no one can work out why. It may be nothing, but it may be something. But you're not going to know unless you do an assessment. You can't know unless you assess. And that's why the deteriorating resident tool really is a fantastic tool that is really the biggest help to nurses in their day-to-day clinical care of residents. Now, what we hear often, we run, when people come on board with PACOP, we offer ongoing support usually in the format of a monthly community of practice, whereby we meet with just online usually in a Teams meeting, chat about two services, how you're going with PACOP, what's going on, just really a support system to help get that program embedded in your organisation, to troubleshoot things that come up, to keep the conversation going. One of the things that comes up a lot, because people can get really enthusiastic about starting PACOP and they're getting everybody on profile. They do start them on outcomes when it becomes obvious, but we keep forgetting to use the DRT. you know, um, and even a good way to pick this up is, in your own clinical monthly meetings or in a PACOP community of practice, how many DRTs have been done this month? If you have a facility of 120 people and you've done 2 DRTs that month, I would say you're not utilising the tool like it should be used. You're not utilising it to its best possible practice that can be of most assistance to you as nurses, and of course which then leads on to excellent resident care. So handovers, nurse to nurse handovers. You all have nurse to nurse handover every shift. If this is a great way to sort of get it into practice, if you're doing paper-based, have a bundle of DRTs right there at the handover. If not, using software, it doesn't matter. The principle is the same. You're handing over to a nurse. They say, okay, this. Oh, and by the way, Fred had a fall today. Immediately the incoming nurse should say, oh, did you do a DRT? Oh, no, I didn't get around to it. No worries, I'll do one this shift. Or, handover. Mary was a little bit off today. She didn't eat and then she just slept all afternoon. Oh, did you have a chance to do a DRT? Oh, yes, I did. It all looks fine and I have spoken to the family, but we'll just monitor her. Perfect. So talk about it. If a resident is concerning enough to mention at handover, they should have a DRT if they're not already on outcomes, there should be a DRT either done, or the incoming nurse should make sure they do one, because what it's doing is giving you information. It's giving you assessment information to try to work out what's going on so that you can give appropriate care. So that is a really good way to get it really embedded into practice, is to just make sure it's front and foremost when you're doing your handovers, whenever you're talking about residents of concern. If you're going to put a referral into your specialist palliative care service, your external specialist palliative care service, chances are they use PACOP. Extremely high chance that they use PACOP, seeing over 95% of palliative care services use PACOP. So include a deteriorating resident tool and a current deteriorating resident tool with your referral, because they use the exact same assessment tools in PACOP. So when they come out to see the resident, or they're getting information about the resident to decide when to come out, you're giving them assessment information of assessments that they understand, because that is the language that they use themselves. And when they come out, they're going to use those assessments. So if you're putting in a referral, for instance, to get it at one of your external specialist palliative care services to come and look at a particular resident because of, the complex symptom load, and you include the DRT, and they see SAS pain is like a 9, problem severity pain is a 3, you've got, a few other things going on, they immediately understand why there was the urgent need for a referral to their service. So make sure you use it, because it's really, what it's doing is making sure we're using a common language for anyone in Australia that's receiving palliative care, regardless of the setting. We've already talked about this, support request for a GP review. Perfect. GPs love information. GPs are not always open to different things, but if you just include the assessment information in your request to them, that is sort of hard evidence that something's going on, and most GPs usually respond well to assessment information. Incidents, we've talked about, anything going on there, do a DRT. And then the last thing, one of the most important things is document it. If you've done a DRT, document it. It's evidence of good clinical care. It's also information for the next people. It's what you need for accreditation. It's what you need for clinical governance. It ties into everything. And we're not talking about extensive documentation. It could just be a line. DRT done due to concern by daughter, nil concerns, continue to monitor. Or DRT done due to concern from daughter, showing increased pain, request GP review. Whatever it is, just make sure you document in the progress notes, like any good nursing system, just to make sure it gets all tied together. Right, now this is just sort of to round out this process. Of course, we've talked about we've got your profile assessment that gets done on admission and then every 3 months. The beautiful deteriorating resident tool, which we love, should be done whenever, however, as often as you like. It's just a perfect, great tool to pick up what needs to be picked up, reassuring for nurses. Evidence of care, great for communication. So that's the deteriorating resident tool. Then through one of these two processes, at some point, the decision is going to be made, I think it's time to start this resident on outcomes. So the only way to start outcomes, again, outcomes is for residents that we think are in last 3 months of life, because we can't know for sure, because no one knows for sure. But if we think, based on the assessment that we've done, that this resident is likely to die within the next 3 months, then we start them on outcomes. Now, when we go into outcomes, we do away with the clinical frailty screening tool, because that's used for prognostication. So we don't need that anymore, because we've already identified that this resident has deteriorated to the point we think they should start in outcomes. But what we do have, not instead of, but an additional tool we have is called the phase of care. Now, we'll just talk briefly about the phase of care, because the phase of care just determines when you do the next assessment. So you complete your outcomes assessment and then you allocate the appropriate phase. The choice of phase is 1 unstable, 1 stable, 2 unstable, 3 deteriorating, and 4 terminal. And for any, when you've assessed and you allocate stable phase or deteriorating phase, then the assessment gets repeated in a week by the nurse, so once a week. But while they're in unstable phase or terminal phase, that assessment gets repeated every day. So you could put someone in unstable phase because of a particular issue, for instance, pain. You need some more pain, you need pain medication reviewed and more pain medication charted. You'd put them in unstable, but then once you come back the next day to do that, and then hopefully the problem's been sorted, the doctors come, and so then you're able to go, okay, great, you've assessed again, and they're back in stable phase. So then that goes back to weekly. And then terminal is actively dying and every day. The reason this is important is because we're talking about how to pick up deterioration. Once someone gets started in outcomes, they are getting assessed at a minimum once a week by a nurse. When things are going awry, unstable or terminal, they're getting assessed every day by the nurse. But then sitting alongside that, their symptom assessment scores are being asked every day by a care staff. So every single day, someone is saying, "How you going, Bob? How's your pain? Is it worrying you? How's your energy?" So we don't need the deteriorating resident tool once we start them on outcomes, because we're already onto it. It's someone's in outcomes, we are already onto the fact that they've deteriorated, and we are assessing them very frequently by the nurse. Minimum, at the longest time, it's once a week by the nurse, but can be daily if required, according to the phase. But every day they're getting asked by the care staff. And that is just the tool that the care staff use, which is the daily SAS, and then the outcomes form for the resident. All right, so this, just to sort of round out this talk, this is what it could possibly look like for a resident that's admitted to residential aged care. They come in, they get a profile, 3-part profile assessment in the purple. You'll see gets done on admission, gets repeated every 3 months. You'll see down the bottom we've got assessments. So they had the first one done on admission. Then before the next one was due, someone said, "I'm concerned enough about this resident," so that someone did a deteriorating resident tool, which is the green. The decision was then made to start them in outcomes, which is orange. So they had their assessment done by the nurse, and then you'll see all the blue is every day. That's the care staff asking them about their SAS. Then again, once a week, they get assessed by the nurse, then the care staff once a week. And then the decision's made. I mean, this is just a condensed scenario, but the decision's made, actually, this resident has really stabilized enough that we think that they don't really qualify to be in outcomes anymore. That's fine. You put them back into profile. Obviously, we wouldn't recommend you put someone back into profile as quickly as this is indicating on here. You would want to keep, if the decision had been made to start someone in outcomes, you would really want to make sure that they had stabilized quite well. We're talking, maybe a month or so before you think, okay, I'm going to put them back to profile. Don't rush to put them back to profile. There's no rush. But the beauty is, once you put them back into profile, if you make the decision to do that, you have the option of that great deteriorating resident tool to use at any time. You don't just have to think, oh, oh, I'm putting them back to profile, but that means they're only going to get assessed every 3 months. No, we've got the deteriorating resident tool that can be assessed at any time of concern. And so they go back to profile, they're in profile. Again, a deteriorating resident tool is done at some point. The decision's made to rebit them to outcomes, and this time they stay in outcomes until the point of death. All right, so this is just a final slide, really talking about what, we all know that there are different disease trajectories for different diagnoses. This is an example of what it may look like. If your trajectory 1, we've got there is the cancer trajectory, the blue line. The next one is organ failure trajectory, which is the orange line. And then the third one, green, is dementia and frailty. So we know that the middle one is like your CCFs, your COPD. Typically, they go down gradually with dips where they have periods of exacerbation, which may or may not mean they're transferred to hospital. They never completely come back up to the level they were before. They go down and then it happens again. And eventually they'll get to a point where they're sort of, really don't come back at all. Whereas the cancer one on the blue one, they can go along quite high functioning for quite a long time with a cancer diagnosis and then have a sudden dip at the end. You'll see we've put a purple arrow at the top, which is the profile collection. So typically people, with any of these disease trajectories, will start off in the profile collection until a particular point, and then the decision will be made to start them in outcomes, where you'll see that we've got the line across and the grey shading on one side. That's when the decision is made to put them in outcomes. The beauty of PACOP, though, and why this is a great slide to talk about, is we don't really have to concern ourselves and get ourselves tied up in knots about what is their disease trajectory of their life-limiting illness. Because what matters, if they've got a life-limiting illness, we are focused on giving them best possible care for best quality of life right through until the very end. So sometimes I can see people get really caught up with a diagnosis or what does that mean, blah, blah, blah. But really, if we're using PACOP, what we're doing is basing our treatment on their symptoms, problems, performance and function, which is how it should be. So we're really just assessing them with the idea of keeping them as comfortable as we can and maximizing their quality of life wherever they are in that moment at the time of being assessed, regardless of what their diagnosis is. Nearly everyone in a residential aged care facility will have a life-limiting illness of some sort, but what we're concerned with is making sure we assess their needs so we can give them the right care at the right time. So that's where PACOP is really is so strong in providing the right care, because we're just concentrating on symptoms, problems, performance and function. So it's almost, it's good to know what their diagnoses are, but it's not necessary for good care, because palliative care, we're just trying to maximize quality of life until death. And the only way we can possibly do that is assess, and then respond to the assessments. All right, so for the last slide, really, we're just going to talk about how we, and if you're involved in PACOP, you probably know about this already, how we provide ongoing support, including really helping embed that deteriorating resident tool into your normal work processes so that it no longer becomes something you have to actively think about. It's just your go-to tool. Whenever anyone's concerned about anything, about any resident, it's just the tool that you go. If they're not on outcomes, it's the tool that the nurse grabs and quickly does it. It's not going to take you a lot of time, but it's going to give you a whole lot of information about what you should do next. And this is the sort of thing we talk about in our monthly communities of practice. Communities of practice are facilitated just by one of your friendly PACOP IFs. We have a small national team, and it's all about just supporting you. It's not about to work out what you've done right or wrong at all. It's just about you tell us how it's going. We share tips and suggestions about how it can help, and we can do helpful things like, mentioning the deteriorating resident tool, coming up with strategies until it really gets into your everyday practice. And that is it. So if you want any more information about the Deteriorating Resident Tool or PACOP generally, don't hesitate to reach out and contact us. We'd be more than happy to help you. And if you are a PACOP using organisation, but you're not yet using the Deteriorating Resident Tool, give it a go, make it a priority, because, really once you start using it and seeing the benefits of it, you're really not going to want to be without it.